I sure will. Hello, everybody. Thank you so much. Can you hear me? I'm just getting over a cold, so if you can't, please feel free to move forward. I'll do the best I can. I want to thank you for having me today. It's really an honor to be here. It's so encouraging to have perinatal professionals take such an active interest in learning more about perinatal distress, also known as postpartum depression, in sort of basic media circles. My name is Sarah Workman Checcone, and I'll introduce myself more in a minute, but I just want to start off by drawing your attention to the title of our presentation today, which is "You Can't Tell by Looking." This has really become, it's actually the slogan of the Wisconsin Postpartum Support Network, and both the ladies that come weekly to our support group as well as our volunteer moms and board members really feel that this creates a picture of the reality of perinatal distress sort of better than any other cliche. The reality is you cannot tell by looking. You can't tell by looking. I mean, you know, we need to all say it over and over to ourselves every morning 5 or 10 times before we start our day. You cannot tell by looking. Every single week I see moms and talk to new moms, both personally and professionally, and I still get hoodwinked. You just cannot tell by looking. And so that's when we have to really tune into our other senses and put our best listening ears on, as I say with my little children, so that we are hearing all those other clues, because our eyes really can deceive us. We're here today to talk about understanding postpartum, perinatal, stress and distress, so that we are able to tune in and see beyond what's right in front of our eyes. As I said, my name is Sarah Workman Checcone. My background is law, actually, not medicine, social work, counseling, or anything else. I started off with a theater background. Always a flair for the dramatic, I guess, and found my way to law school. My first child was born shortly after I passed the Florida bar, and I had always been looking forward to being a mom, and I was very surprised when I personally experienced perinatal distress. Oh, okay. They said that I needed to not use that speaker because for the sake of the webinar. If anyone has another preference, I'll try to speak up louder. I'll try. Okay. I am the founder and executive director of a new 501c3 not-for-profit. As of 2012, I started the Postpartum Society of Florida, and our mission is to ease the transition from pregnancy to parenthood in the postpartum period. Before we get started, I always like to know what our experience has been with perinatal distress. I certainly do not want to throw anyone under the bus, so I don't like to ask about personal experiences, but I'd like to see, if it's all right, by a show of hands, if anyone in their professional experience thinks that they have ever encountered someone who is suffering from postpartum depression or anxiety. Yes? Okay. All right. I'll ask a different question. In a personal sense, maybe a family member, sister, mother, friend, encountered anyone that you felt was experiencing perinatal distress? Show of hands. Okay. It can be a very different experience to talk to someone professionally versus personally when we're so close to the problem, especially if it occurs within ourselves. I have 4 children myself, and I believe that I experience perinatal distress every time. As I said to a friend recently, I said, babies coming out of my body makes me go crazy. That's just the way it is. I delight in them. It's just quite a ride. It's quite a ride. So I'd like to know, before we get started, what what are you hoping to learn more about today? What would be useful to you in your work? Anybody? Yes.
I'd like to know the difference between normal baby blues
Right.
and an easier way to detect postpartum
Depression.
and the first recommendation that we would make to a mother if you feel that she has postpartum depression as opposed to normal baby blues.
Okay. Thank you. Yes.
A mom who has had traumatic birth
Yes.
is more likely to depressed. There's a cascade that follows that.
Yes.
What can we do intervention-wise early on to help her process that a little easier quickly so it doesn't cascade as quickly or as quickly?
Very good question. Thank you. Thank you. Yes.
The current state of research on meds for mild to moderate symptoms.
Yes.
I've read that it's not really as effective as we thought.
Mm-hmm.
They overprescribing for mild to moderate symptoms.
Thank you. Okay. Anybody else? Yes.
I'd like to know how do we differentiate on my unit we take care of leaky mom.
Yes.
My mother was going home without her baby. Her baby could go born all the way to 32 weeks. She's going home. Her baby has to stay whatever that the baby's going through. How do you differentiate between a normal reaction of leaving my baby behind and this sort of thing?
Okay. Great question. Anybody else? Okay, super. Because we are blessed with a reasonable amount of time today, often I'm sort of racing to not be a flipper in these presentations. Please feel free to ask questions as we go along. I have no problem with that. I know sometimes it's hard to keep a train of thought when something sparks a question. So these were from some of our group moms. We have a weekly support group, peer support group. It's not group therapy, but it's far more therapeutic than many therapy sessions, as our moms say. We usually have 8 to 12 moms and their babies every week in Sarasota, and these are some of the fantasies they said they had. So they're all funny, but I mean in sad ways. But which one in particular? Let's see. So babies start learning the moment they're born. Oh, that should be they are born. I can't wait for all the fun we're going to have together. Oh, that's a harsh surprise. More moms than we would expect feel that way. I mean, motherhood, just like romantic love, has really been commercialized and sold, packaged, so that we believe that it's going to look a certain way and smell a certain way and feel a certain way and it's going to be fulfilling in a certain way, rather than the reality of it that generations ago we learned from our neighbors and our aunts and our mothers that were right next door, that it's messy and loud and exhausting and it takes a while to adjust. And the people that say get through the first 3 months, we just had a group this week, someone said, I can't believe someone told me to just get through the first 3 months. It's worse now, and the baby was 4 months old. We're like, yeah, I think people say that just so you don't walk away. Just so you're like, really? Are you sure? All right. Okay, I'll give it 3 months. But it is, and we often say in group that early motherhood is more like being a nurse than a teacher. So if you were looking forward to being a teacher with your baby, that's going to happen, but not at this stage yet. Baby is still just, as mushy and vulnerable as in the womb. And so we're in that second half of the womb stage. Going to share all baby care responsibilities equally. Wow. Wow, yeah. I mean, oh, Lord, yes. And, you don't want to burst that bubble when they're pregnant. You just can't say anything because you don't want to create static in the relationship. So you're like, oh, that's great. Good for you guys. All right, here's my card, and we'll just talk later. Because, A, if she's choosing to breastfeed, obviously there's that, which, of course, we want to support. And I have to say as a disclaimer, first off, I breastfeed all my babies. I breastfed all my babies for more than a year. I'm a huge believer in the value. My youngest is 17 months, and she's still being breastfed. That said, she's being breastfed. That being said, our support group has a lot of bottle feeding moms, and we just love our moms. That's it. And I always get a little emotional because they are so sad to think they've ruined it from the start if they weren't able to get to the point of easy, comfortable, not, I don't mean just easy, functional breastfeeding. And to feel they failed before they even began, it's just heartbreaking. And so we are very, very protective of all the good that our moms do, regardless of how we feed our baby. Fed is best, we say. Fed is best. I'm going to use my maternity leave. Yes, this is a huge surprise that all day we are busy and yet we did nothing. That the moms often say, I was busy all day and I did nothing. And it's very, very frustrating to try to structure your life around this mysterious, exhausting new phase. So with all that disillusionment, we end up in sort of a fix. So what is postpartum stress and distress? Some people say it's a women's issue or family issue. It's certainly a health issue, but how would it also be an education issue? If she loses confidence in herself, will she necessarily have the esteem for self-actualization? I mean, is she going to get out there and try? This is a crossroads. This could be a huge stumbling block for her for the rest of her adult life if she feels that she failed as a mother. Like the most basic thing that she, as a woman with a baby, is supposed to be able to do. So it certainly then goes to being an economic issue, because that goes to the family's long-term financial stability, as well as her feeling good about herself and her ability to contribute to her family. Tragically, it is also a violence and child abuse issue. And I don't really mean that women with postpartum depression hurt their babies. That is a total misnomer and unfortunately gets sensationalized in media to a tragic degree. What I am talking about is the incidence of long-term untreated depression that results in self-medication. We know that children under 5 are far more vulnerable to child abuse in those early years because it is such a taxing experience to be home with little children. So if she feels isolated, trapped, unsupported, that's when our patients, and tempers wear thin. It is not postpartum depression that makes somebody harm themselves or others alone. It's not that alone. It is a multifactorial situation, but it certainly can be a risk factor for family violence if someone feels unwell, mental illness of any kind. Substance abuse, yes, self-medicating certainly occurs. We have jokes about drinking wine in the laundry room at group, but we want to make sure that those are jokes. Those are jokes. And we want to be really careful that we're getting treated the right way. And certainly a humanitarian issue because we really are all one family. I mean, I look at the ladies' babies in our group. Those are my children's friends one day. Those are their peers. Those are their coworkers. We're all in this together. So we really need to reach out. To clarify a little bit, the alphabet soup of trying to explain this terminology. I've come to call it perinatal distress. Most people know of this affliction, this illness, this very real illness as postpartum depression. But it frequently presents as postpartum anxiety. So we started calling it postpartum depression and anxiety. Some folks, the clinicians, used to call it perinatal mood disorders, but once again that really didn't include the anxiety, which is frequently the first red flag. So then we started calling it PMAD, perinatal mood and anxiety disorders, which is really a mouthful. Nobody knows what that means. If you talk to a young woman or a new mother and you say, sounds like you're experiencing perinatal mood and anxiety disorder, she's like, oh my gosh, no, I don't want that. Take it back. So frequently we talk about postpartum stress and distress, or perinatal stress and distress. Stress would be more of the baby blues, Everybody has stress. Everybody has stress, and if there's someone who hasn't, I would love to talk to her and find out how she did it. But when someone is experiencing distress, where crisis is escalating, that's when we're looking to intervene. Yes?
Are we separating that from postpartum post-traumatic stress disorder? So we put these in different categories?
No, you'll see as we proceed, there are 6, currently, there are recognized, and as I've come to think of it, as 6 expressions of perinatal distress, and one of them would be PTSD. So that's why we had perinatal mood and anxiety disorders encompassing depression, anxiety, panic, OCD, PTSD, psychosis, but we just put that under a big umbrella. So how did this all come about? I've had some folks of older generations, especially men, God bless them, say, well, in my day, you know, we didn't have any of this postpartum depression and so on and so forth. But boy, our culture's changed. It's changed dramatically. Said to the ladies in group before, it used to be when there was one road, no one got lost. We all knew what we were supposed to do, where we were supposed to go. We knew who our friends were. We knew where our parents were. We didn't move around so much. Our spouse could get a job and keep that job for years and years. We had benefits. We moved to a neighborhood school. We knew that we were going to meet other people. We had our church communities or, communities of faith. One of the biggest risk factors I see is a mom who is isolated as well as you know. We live in a fractured mobile society where someone recently moved and then they have a baby and they think, oh, it'll just be me and a baby. And, oh my gosh, then sort of the anvil drops. I mean, it's far more taxing and exhausting and scary. To do this alone, we were not meant to do this alone, and we say that a lot in group, is that ladies think, I should be able to handle this. I should be able to feel better. We said we need to stop shooting all over ourselves. Like, no more shooting. Right? We have on the board the word should with the line through it, and one day I was saying that, and someone's like, what are you saying? I'm like, no shooting. No shooting all over ourselves. Because these changed expectations, these images and expectations that I can certainly say mothers of my generation see, can be quite a high bar that we set for ourselves. And partners, how can they understand either? If they've never been a dad before and they're not watching anyone else do it, how do they know what to do? We learn by example, we learn from each other, and when we're so isolated, it's a whole different level of a learning curve. So overall, in the postpartum adjustment period, the common statistics are 80% of new mothers will experience what's called the baby blues. We'll talk about that more in a second. The CDC statistics state that 15 to 20%, I believe the last pass was 17%, of new mothers will experience perinatal distress, postpartum distress. One of those 6 expressions I mentioned, anxiety, depression, what have you. But there was a study done in 2012 by a researcher named Barbara Yon and her associates that looked at how do those numbers look when we apply universal screening practices. And it was more like 35%, so 1 in every 3. And that's incredibly high. I mean, wow. So we're talking about a public health crisis, really. And I don't say that to be an alarmist. I don't think that fear is inspiring. I think that this is a good time to start paying attention for our society in a new way. Paying attention to what it looks like to become a mother in the modern age and make our communities work in a better way for that. Postpartum psychosis, I'll speak about a little later on, is less than 1%. Very rare, extremely serious. So the baby blues, what are they? As I said, affect 60 to 80% of new mothers. The important thing to know about the baby blues is, crying, tearfulness. I remember when I had my last baby, 7 days, almost to the minute of her delivery, I started crying and I didn't stop for 12 hours. Everything just came down, sitting at the kitchen table. And I'm sure it was a hormonal reordering of everything, you know, all the balls just fell. But that was the baby blues. The overall mood was up. And I don't know why I'm upset. I don't know. And then the baby comes by, oh, hi, sweetie. Overall, up and down, but the overall mood is up. Certainly impacted by the physical exhaustion and strain of labor and delivery, as well as sleep deprivation. So how do we know, to your question, if it is baby blues or PPD? Well, we know by timing, severity, and duration. And as your takeaways for today, this is the big one if you've not seen this before. These are the 3 things that you need to know and be looking for in a new mom. Timing, when was the onset? Severity, how serious is it? And duration, how long is it lasting? Now I want to be clear, these are guidelines. So you don't look at something and say, we don't go, oh, but it's only been 10 days. So I'm sorry. Come back next week and we'll see what we can do for you. No way. So someone can, especially if they have a history of depression and anxiety or other psychiatric illness, bipolar disorder, schizophrenia, absolutely can crash immediately. So this is just a guideline. The reason why we have these guidelines is because if you've got a mom who's crying and it's a week out, 3 days out, she's like, do I have postpartum depression? You can say, we don't need to know that yet. Let's just work on taking care of you, and then we'll just kind of see what happens tomorrow and the next day. We don't need to rush to label it if she's up and down. But if it's down, low, not interested in baby, not interested in getting up, not interested in trying, won't talk to anybody, that's it. Those are the symptoms. Those are the red flags for postpartum depression right away. The important thing to know about this too is in the past, our expectation has been we go to our 6-week appointment and get the stamp of approval, and then presto, postpartum is over and life can just, you know, go back to sort of browning ground beef or whatever you were doing before. This is it. Welcome to motherhood. Absolutely not true. Not true. That's a huge lie, and we need to make sure that all of our moms know that's a huge lie. That's when the doctor gets to put your file away. That's what happens. That is not when you are supposed to be healed or well, okay? No. At least 9 months. 9 months to bring the baby out, 9 months to get ourselves pulled back together. Really more like a year. What I see in group, this is totally anecdotal. I have no research to support this, but it's really evidenced itself to be true. 3 weeks, 8 weeks, 4 months, 7 months. Those are the crash points. And I will frequently see a mom come in at 3 weeks, and what she says then is, I made a mistake. I shouldn't have done this. This was the biggest mistake of my life. She won't say that. She won't say that for like 2 hours. But after the group is over and she's starting to leave, you go and pat her on the back, and then she starts to cry because someone touched her, and she'll say, I think I made a mistake. That's usually at 3 weeks, having the baby. Because she was preparing for delivery. Everything went toward delivery. And now delivery is over. And now I have the baby. Oh my God. And so at 3 weeks, maybe the meals have stopped coming, dad went back to work, maybe her mom went back to work. Who knows? But now it's getting real. I'm fine. So at 3 weeks, that's a huge touch point. And now she's starting to process all of the delivery too. The adrenaline is wearing off, and she's starting to think back to, oh my gosh, what happened? And the lack of sleep is really setting in. At 4 months, it's usually that everyone said get through the first 3 months. I did that, and now it's not any better. Or, again, it's another wave of sleep deprivation. The bottom fell out. Or baby was sleeping a lot in those first few months, and then baby woke up. And now baby's still kind of doesn't know what to do because it's a little baby, and you have no structure, she has no structure to her life yet, and is feeling that horrible isolation at home. I don't know if I can keep going like this. Yeah. Can I? Oh, it's okay. I think I gotcha. No sweat. Awesome. Okay, and then I need to move this. Yeah. There we go. Sorry, I usually use a Mac. There you go. So 3 weeks, as I said, is when I feel like I've made a mistake. 8 weeks is when baby sort of wakes up and isn't napping the way they used to. I don't know what's wrong. I don't know what's wrong. 4 months is I just got through the first 3 months. And then 7 months sometimes is realizing, like, the world moved on without me. That's often a point of an identity crisis, is realizing I don't know if I want to go back to work, or like my friends didn't come and see me, or this is not what I thought it was going to be, or I thought my partner was going to participate more. I mean, she may have gotten the rhythm of mothering, but just realizes that going back to normal isn't going to happen. There's a new normal now. And so to say we can screen at 6 weeks for this is not going to work. It just is not going to work. We need to keep following up and keep following up throughout that entire first year. Severity, as I said, with baby blues, overall the mood is up. Postpartum depression, anxiety, overall the mood is low. Anxiety can be very confusing this way, and we'll get to this in a minute, because it doesn't look like her mood is low. It looks like she's a really good mother. You know, I'm going to sterilize this, I'm going to clean it, I have to fold it, no, get out of my way. But if she goes to lie down and she cannot sleep, that is a serious red flag, huge problem. No one can sustain that. So if you've got a mom that even when the baby sleeps, and I'm not talking about she has to nap, nobody can sleep on command, but if even she says, even when I lie down at night, I cannot sleep. Or this is a huge one, staying up between feedings to clean or get stuff done. I've been there, okay? Not good. So we want to be sure we're monitoring how much she's able and willing to sleep. Duration. Yes, the baby blues is a finite. That's the easiest way to tell if it's the baby blues. It should not last more than 14 days, maximum. If it goes on and on and on, it's turned into something else. Oh, there we go. Yes. So here are some statistics, because everybody loves those, but really the point is that the number that we have that indicates who is suffering from postpartum depression, perinatal distress, is out of whack with our actual data and what we see. So we can see that, 1.5 million women annually, this is a serious issue. As I said before, so these are the 6 most common expressions of postpartum or perinatal distress. Got depression for sure, anxiety as well, panic, obsessive compulsive disorder. We find that eating disorders is frequently a sort of a, I don't want to say a trigger, but if there's a history of eating disorders, it certainly has a relationship with OCD. Post-traumatic stress disorder and psychosis. Obsessive compulsive disorder is a lesser known expression of perinatal distress, postpartum distress, as well as PTSD. But boy, oh boy, is it important that this be diagnosed correctly. It is so important. I mean, if I impart nothing else to you today, it is that when mom finally goes for an evaluation and someone tells her that she has bipolar disorder, please encourage her to get a second opinion. Absolutely, the perinatal period can awaken a latent mental illness in someone. That is totally possible. Absolutely. However, if she goes to an ER and says, I'm having racing thoughts and I can't sleep at night, and it looks and walks and smells like a manic episode, she's much more likely to be diagnosed with bipolar disorder, as opposed to a man who, if he gave those sort of symptoms and said he'd been through a recently, traumatic experience, such as a traumatic birth, he would be diagnosed with PTSD. And there are statistics to support that. Women tend to get diagnosed with bipolar disorder and men with PTSD. The meds are different, the treatment is different, and the stigma is different. And that goes a huge way to her recovery, is just believing that what she has is not her fault and that she's not crazy and that she can get better. So here's the grid of symptoms. I'll give you a minute to take a look at it, and I'm just curious if you're surprised by anything or anything jumps out to you. So what do you see across the columns? Now, anxiety and overwhelmed. Yep. And then if you look down a little bit lower, intrusive thoughts, poor focus, intrusive thoughts. Okay? So everything's working against her. And if anyone's experienced this personally or been really close to it, you know what I mean. If someone is already overwhelmed, how easy is it to make a simple phone call? If she can't focus enough to find the number. Anxiety, a lot of our moms are afraid they won't know what to say on the phone and that they'll sound crazy or that someone will take their baby away. Someone will take their baby away, okay? And this is especially dear to my heart because as an attorney, my last semester of school I spent with DCF. I mean, my interest is family law, and yet I was still scared someone was going to take my baby away because that's what you're afraid of. Because you think, I can't tell anybody what's really going on in my head. I mean, you know, that's the ultimate fear, because then it's a runaway train, especially moms that are experiencing intrusive thoughts. And the more they try to push those thoughts away, the worse they get. Cannot push them away. So frequently when it comes to helping a mom get help or treatment, this is where we come in and can do an amazing job of bridging that gap, which is creating networks in our own communities so that we know we aren't saying, here, call this number. We're saying, I have a friend named Pam. She sees moms that have this kind of thoughts and issues all the time. She's a mom too. I know her. Can I call her for you? And maybe she can give us a call back while I'm here. And you can write it down in a place, make sure dad knows too. It's hand-holding. They need every new mother needs that kind of love and support, and frequently as lactation consultants, I have many moms say, no, I didn't see a therapist, but I had a lactation consultant. Yes, right? Yeah. I mean, a lot of crossover with y'all and mental health professionals because moms are turning to you guys as their, you know, as their personal counselors in that moment. And so there's such a bond of trust and attachment, like, oh, I'll call her, she'll know what to do. You know, I mean, so this is an opportunity to network with mental health professionals in your community so that you don't have to shoulder that alone, but you can be sure that she feels led by the hand to the next step, because it might be the only time she's willing to reach out. This is, you know, you can put this on, needle pointed on a sampler. High comorbidity exists between depression and anxiety symptoms in postpartum women. I spoke at a new moms class recently, little, you know, moms and the babies, and boy, they looked great. Holy smokes, they looked amazing, like full makeup and hair, like it was incredible. I thought, gee, I'm not dressed for this. If you talk about depression, that's not what's going on. They're all sort of all on point. And I did have one mom come up to me afterwards who looked fabulous. Baby looked amazing, and she said, I think I have what you're talking about. And I said, what makes you say that? She said, I just can't calm down. I feel like I can't breathe. And so, once again, goes back to our title, you cannot tell by looking. Frequently, the ones that look the best are the ones that are working the hardest to feel better and to look like they're making it. PTSD. Boy. So what's the key to PTSD? It's understanding that it is an anxiety disorder after a terrifying event or ordeal in which grave physical harm occurred or was threatened, and this is based on the perception of the person in the situation, not actual harm. It all depends upon her perception, because as they say, perception is reality in that sense. So look at this. Complete PTSD, very low, but partial PTSD in a quarter of births. Quarter. Walking down a hallway, there are eight rooms in the L&D unit. 2 of those women are going to walk away with PTSD symptoms. Yikes. You'll see down here, this is, I wrote this book as a guide to new moms, and it's incorporated a lot of stories and things that I've heard from moms over the years in our group and as friends, things that we all wish we'd known before we gave birth. And it's divided into 5 chapters: before delivery, labor, birth, the initial recovery, like in the hospital, and then the postpartum recovery. And the reason why I did that was because I experienced PTSD, partial PTSD, after the birth of my first child, and I know it put things on a really bad foot. My husband's a physician. I have no ill will toward the medical community at all. It's just communication is everything. Communication is everything, and that's why, boy, we really encourage moms, especially young moms, to have doulas, so that there is a third-party sort of advocate in the room, because any more, I mean, especially young moms get treated so badly, which is just not right. And also because the medical system it's just changed, and frequently moms are not communicated with or told what's happening to them. I mean, there are many stories to tell, and I know you have them too. So if a woman is feeling out of control during labor or delivery, yes, go ahead.
I just have a question because I'm working in the hospital. I think that people don't go to childbirth education classes anymore. They don't go to breastfeeding classes. When they get to the hospital, they think, oh, I'm in labor, I popped this baby out, life is good, it's going to be breast, life is happy.
Absolutely.
They're not doing that education beforehand. So do you think some of that is contributing to what their perception is of a traumatic event, because they are not doing the work behind, preparing.
Right. That's a great point. And I think that, yes, because frequently we've got, I mean, I know at some of our local hospitals they have sort of childbirth university on the weekend, but a lot of them don't want to do it during the work week. Both people are working, or they've got shift work, or they've got children, or they've got all these, we all have reasons why. Everybody's busy. I mean, that's a fact. What I'm talking about is more, I'll give you an example. When one of our moms was, she had labored for a long time, 30 hours, long time. And she ended up having to have an emergency C-section. And while they were trying to, the baby was stuck in the birth canal, and while they're trying to get the baby out, she heard the physician say, I don't know if I can get this baby out. And she said, of course, what? From the other side of the sheet. What? He said, oh, well, maybe if I just push down on her harder, I can get the baby out. And so, oops, can you get that one? So we're talking about sort of simple sensitivity training. I know of another mother where when she was rounded on post-birth, she had had a 4th degree episiotomy, and the physician that came in to check her, she was asleep, and he checked her wound without introducing himself. I mean, seriously? It's like a step away from assault. I mean, really? So I'm talking about a level of just treating people with some civility and patience, introducing yourself when you come in, asking a question like, may I examine you? Or, I mean, a little advance notice just goes a long way to when someone is being touched, especially for moms who are survivors of sexual abuse or assault, and we definitely have them in our group. And so to just be told, you know, here it's time to push, and they'll tell you when, but it really can help a lot to say, we're going to do this for 2 minutes and then you're going to rest for 1 minute, so that they just have in their mind, how long is this going to happen? How much is it going to hurt? You know, who can I talk to if I can't keep going? Communication is everything. And some women, extroverts, need that oral communication. They need to be able to talk through things to process it. Moms that are more introverts might prefer to have a chance to read something and think about it and then ask questions. Because when the doctor comes in or the nurse comes in and says, blah, 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 do you have any questions? A more introverted mom will be like, no, I don't know what you just said. Like, I guess not. I'll be a good patient. You know, because as women, we're also socialized to not bother anybody. So it's really, really helpful when we communicate, especially in those emergency situations. And also when it comes to episiotomies, I know personally when I had an episiotomy, I just heard scissors. That's what happened. No one said, we need to give you I just heard scissors. And I looked at my husband and he's just like, you're fine. I'm like, oh, sure. So, yes, go ahead. Yes. Teen moms, yeah. The teenage moms specifically. Mm-hmm. Oh, yeah. Oh, yeah.
So that's a really, that's not just her bio story.
No. It's true.
And who do we go to about that?
I know. Well, I mean, here.
I'm sure everybody knows. But
Well.
The nurses I know are not that kind of people.
No.
And I don't think anyone in here would be prejudiced against a mom unless whether someone paid attention, whether she paid or insurance paid or the state paid.
Mm-hmm. Well, okay. Let's be honest. I mean, staying unbiased and remaining civil and compassionate is fluid for all of us. All of us. I mean, based on an experience that I might have the best intentions with something, and then if I have an experience with something else, then I'm going to take that information and I might apply it in the wrong way. So I think certainly anybody can make those kinds of errors. It's not about being a good or a bad person. It's about having, I would say for the medical community, I don't think you can't crawl inside someone's head and teach them how to talk to somebody else. You can't do that. But you could make suggestions about something as simple as, before you touch someone, ask if you may, tell them what you're going to do and how long it's going to take. And let them know that if it hurts, you can ask me to stop. And then, if they say at some point, you know, now we're in a situation where it might hurt, but we need to just keep going, but it'll be over in this amount of time. It's about empowerment. We want to make the moms feel more empowered. I think. Right.
You're probably going to get the red carpet.
Right.
But what do we do to help our moms? Because I'm wet.
Right.
So my moms are mostly, not all, but many of them at least, are getting state aid.
Right.
What do we do to help them advocate for themselves so they get treatment that's equitable?
Well, there are two things off the top of my head, but that's a great question. The first is, as I mentioned before, is finding a doula who's willing to work on a sliding scale.
If she still sees that.
Mm-hmm.
This doula friend.
Mm-hmm. Still sees it. Well, and that's why I say, like, we can't crawl into someone's mind and change their mind and heart, but we certainly can arm ourselves with an advocate, you know, like, yeah, so that she feels, so new mom feels that someone's on her team.
And then maybe write a letter afterwards to the president.
Well, yeah, absolutely. I mean, you know, make some suggestions, or say to the mom, you know, what would you like to know? Allow her to have a voice. But really, it's like having a lawyer when you go to court. It's just a good idea to have an advocate for yourself in that kind of environment. Yes. Ah. Oh, thank you. Thank you. Yeah. It's critical. Okay. Thank you.
Early in my career as a practice lactation consultant, I started seeing mothers who were grieving over treatment or lack of treatment or birth, and some of them were really legitimate. My husband is an attorney. And I started telling them right off the bat, let's call, let's write a letter.
Yes.
Always
take action. Mm-hmm. Absolutely.
Writing it down sometimes helps her feel empowered.
Absolutely.
Or whatever. But I even had a mother one time, we contacted the hospital and they had her come in, talk about her grievance with the attorney and the infection control, somebody.
Yes.
Brady was giving somebody else's milk.
Oh my God.
And, I knew she couldn't move on with her life until she had somebody to listen to her talk about this.
Absolutely.
With her lactation problem because she was stuck with this in the past.
Stuck within the past.
I knew I had to do something. So
that's excellent. Yes. Absolutely. And Ellen, you brought up a really important point, and that goes to what you were asking earlier about how to help women who've experienced birth PTSD, is that it's about getting to tell their story over and over and over and over, as many times as they need to, and saying, but you have a healthy baby, forget that. They have plenty of people that are going to say that to them. That just, forget it. This is what happens. Mm-hmm. Exactly. Oh, for sure. Oh, yes, you must. I mean, this is, I love sort of, fitting things into overarching principles. And this is one of those principles, is how therapeutic it is to tell the truth. It really is. I mean, that's why, when atrocities occur in, faraway places or right here in our own backyard, we have things called truth and reconciliation commissions, because it's important to be able to, like going to the hospital, confront your accuser or what have you, come face to face and be able to tell your side of the story. I mean, it can't change the past, but it can allow you to move on. And for folks that, there are so many women where the people in their lives say, oh, just forget about it, put it behind you, focus on your baby. We say, but they don't know. You've been through a war, and your body was the battlefield. And they don't see the scars because they happen on the inside, but they're real. They are real, and you have every right to be hurt. But it's fine if they can't hear it. They might be too afraid that she won't get over it. They might be too afraid to hear the truth. They don't want her to wallow. They don't want, or this, partner. Yes. Just move on. We had one mom's mom who said she had a very traumatic birth and nearly lost the baby, and her mother said, you should change your birth story. Yeah. She said, she's like, that's a bad birth story. You don't want that one. Think of a different one. Like that, sorry, that's not working for me. So we want to be a listening ear no matter how many times someone needs to say it, and also to encourage her, again, with extroverted and introverted folks where they get their energy. The extroverts will probably need to talk about it more. The introverts may not be able to talk about it, but encourage them to write it down or say, do you want to write this in an email to me and I'll read it? Sometimes it helps too you can encourage some moms to just tell the story to their baby. You know, tell them the story. Tell anybody who will listen. You know, this is what happened with us. And frequently what will happen is she'll see as she's going through it, and then she focuses on the baby, that can help break through something. She'll be like, but you're here. And then it's better. It's better. So postpartum psychosis, I have only seen one case of true psychosis in my experience so far. It's only been a couple years. But it is extremely serious and rare. This is the condition that yields the highest incidence of potential violence. 5% of women with postpartum psychosis commit suicide, 4% commit infanticide. This is the Andrea Yates kind of stuff. That's why that is different than postpartum depression. Okay, yes. Andrea Yates, if you remember the tragedy from Texas. Yes. Yeah.
I just whoa. And yeah.
Yes. Yes. Now, yes.
Oh, I'm sorry. Do you think some of these moms have underlying conditions?
Yes. Yes. There is certainly, and that slide is coming, yes, that women that have a history of bipolar disorder or schizophrenia are definitely at a higher risk for postpartum psychosis. Absolutely. With the case of psychosis I saw a mom, and for 2 weeks something was a little off, and then it was totally wrong. Something was just wrong. And kind of coached her partner on the phone to drive her to the access center at the mental health hospital and it's not a great fit. I mean, because here she is, a mom with a nursing baby, and now we're putting her in inpatient in mental health. It drives you crazy because you know that that's not good. But what's the alternative? I mean, she needed help. She absolutely needed to be hospitalized at that point, but it just runs contrary to everything that's going to be good for that dyad. So if I had a wish list, it would be that we could have a mother-baby unit in every local hospital. You only need like 2 beds. I mean, it doesn't happen all the time, but just a couple would make such a difference. So there's something to go lobby for. But postpartum OCD and psychosis, why is this important? Okay. It's important because frequently moms that are experiencing intrusive thoughts, show of hands, have we all heard of intrusive thoughts? Okay. So intrusive thoughts are scary, are frightening. It can be flashes, images, verbal messages. There's an amazing book. I really encourage you to get it, Dropping the Baby and Other Scary Thoughts by Karen Kleiman. She pretty much is the seminal source for postpartum distress information. This is an outstanding book, and it's called Dropping the Baby and Other Scary Thoughts. I don't necessarily recommend it to moms that are in the throes. It can be hard to read, but it can be really useful to read as a support person. So if a mom is experiencing scary thoughts, intrusive thoughts, she is overly concerned about becoming crazy. She is afraid she's going crazy. And what does that bring us back to? Afraid of losing her baby because she's going crazy. So what is our job? To educate her that thoughts are not actions and feelings are not facts. There was a story on NPR recently, I posted it to our secret Facebook group, about what occurs in the amygdala when someone cascades into obsessive compulsive disorder. That fight or flight response in our brain gets out of whack. And we start, as mothers, when we have that baby, biologically and chemically, I call them mommy switches. All the mommy switches get turned on. because we're charged with recognizing danger and being responsible and taking care of our babies and responding to their cries, and that's part of what nature has put in us. But for some moms, those mommy switches get turned on and then they don't get rheostated down. They stay on and they get brighter and brighter. So we start seeing danger everywhere and start being afraid that the danger will come from us. Like one mom said that she would go take the trash out to the trash compactor, and baby was in the stroller. They live in an apartment building, and would go through her mind what it would look like to throw the baby in the trash compactor. And every time she was like, my God, why would I think that? Who thinks that? I wouldn't do that. But it scared her so much that it would even occur to her, because she was just exhausted, all chemically messed up, didn't have anyone around to say, oh yeah, those weird things come through, my mind too from time to time. But it went on and on and on. And the important thing for us to let moms know is, because they'll be afraid to talk about them. I mean, I've seen women 3 or 4 or 5 times before we really get to the heart of the matter about intrusive thoughts. Is that thinking something doesn't mean you're going to do it. This happens to a lot of moms. You're not alone. This is not your fault. And you definitely can feel better. You don't have to suffer like this. Yes?
Have you heard of, if I remember the title correct, dysphoric guilt rejection?
Yes. Yes. Kind of that too. Yes. That kind of awful experience before latching occurs. Is that right? When on the letdown. Uh-huh. Yes, and I'm glad you mentioned that. We have that information about that on our site as well. Because if a mom is people know that she's not feeling well, and she could be weepy and scared and anxious and irritable because she's having intrusive thoughts and not talking about them. So she goes and talks to someone about her postpartum depression or postpartum anxiety, but never mentions this, and she gets Zoloft, and maybe it helps because it can help intrusive thoughts, or maybe it doesn't, but she doesn't talk about it anymore because that was what was supposed to help, and it didn't. So now I guess this is just who I am now, and that's the greatest fear. This is just who I am now. So we want to be sure that she knows some moms have intrusive thoughts. It's just something chemically that's going on in a new mom's brain because we're oriented to seeing danger everywhere. And now it's resulting in obsessive and compulsive behavior, obsessive thoughts and compulsive actions to try to guard ourselves against doing something dangerous. And there is medication that can really make a difference in your wellness. And then moms say, I don't want to take medication. That's totally fine. You don't have to. Some women, I use this analogy a lot. If you shattered a bone and you needed to heal the bone and have physical therapy, but you're in so much pain you can't go to physical therapy, how are you going to get well? The bone will heal, but it won't get stronger. So you're in a lot of pain right now, and the medication will just dull that pain so that you can get your sleep and your eating and your showering and your smile back enough to be able to face your responsibilities and feel like you can bring baby home. Because moms that have heavy intrusive thoughts, if they can, they will separate themselves from their baby. They'll take baby to grandma's for 2 or 3 weeks, or they won't ever be alone with their baby. They're like, I'm afraid I'm going to do something. They don't trust themselves anymore. They don't believe that they can control themselves. So what we want to do is make sure she knows this is nothing she did wrong. This happens, but people don't talk about it, and there are lots of ways to get better. She does not have to suffer. She can take some medication for a while, get her strength back, go through the therapy, and then gradually wean off. Women do it all the time, and they can actually enjoy their babyhood. Mm-hmm.
What is the usual medication they suggest for her?
Well, I'll tell you, first of all, as a disclaimer, I need to say I'm obviously not a medical professional. There is a variety. Some women do find that Zoloft is helpful. Some women take Celexa, Lexapro, Wellbutrin. Those are usually the antidepressants. Sometimes, from what I understand, the anti-anxiety like lorazepam, but that's highly addictive, and so frequently our moms are very reticent, reluctant to take that. But what can be helpful are mood stabilizers as well. I know for one mom, FLCA was very helpful to her. But here's what's so important. We cannot just stop this cold turkey. I mean, this is what always happens, right? Is I feel better, and then she stops, and then the bottom drops out. And I've had dads even say, I think I need to go. I had one woman call me and say, I've decided to leave my husband. I was like, wait, what? Like, what just happened here? And when I communicated with him, he was so calm about it. He's like, I think I need to counter pills. I was away last week. And yes, she had stopped taking her medication. And she's weaning off it now, but that abrupt shift. And so, I mean, the more we can reframe medication in terms of this is good for you to feel better, instead of this is a sign of failure because only weak people take medication. Forget it. This is to just tamp down this adjustment pain. You're going through some pain. You would take a painkiller. Your brain is going through some pain, and we just need to ease that pain so that you can get the work done that you need to do. We want to know that, and we'll say sometimes, people are afraid of becoming crazy. If you're afraid that you're going crazy, you're probably not going crazy. Because if you were crazy, you would think you were sane. So that's a good sign if you think you're going crazy. Yes, and it's funny when that's a source of relief, like, oh, I didn't think about it that way. Yes, it is. So for a woman who's experiencing postpartum psychosis, she will not recognize her actions or thoughts as unhealthy. No. It all seems to make sense. Frequently there are hallucinations. And the big one at the bottom, that something is guiding them that of a religious or spiritual nature. The old, they'd be, this is the right thing, God is telling me to do this, the baby would be better off without me, or I'd be better off with, that kind of thing is different than postpartum OCD. But it's so important that we work with, as you network in your communities with mental health professionals, that we be sure that counselors and psychiatrists are aware of this distinction between postpartum OCD and psychosis and OCD and depression and anxiety, because it can be treated differently with different medication, and also that just changes the conversation. Yes? Yeah. Right. Nothing. Yep. I think that's a problem. I mean, no one should be taking, in my opinion, as a lay provider and as a mother, I don't think anyone should be being treated for postpartum depression through medication alone. That's just not going to work. I mean, and using the same analogy, listen, I don't push medication, but I have seen for some women it makes such a huge difference in their ability to mother their child that why not, be willing to give them that tool. But at the same time, when I've said, but you also wouldn't take a painkiller for a broken leg and lie in bed and expect to be able to get up and walk in 9 months or 6 weeks. You've got to get up and do the hard work. We've got to focus on eating, drinking water, sleeping, showering, getting some basic needs. Got to work on the basic needs, got to reach out for mental, counseling, come to group, get some fresh air, but the medication can just help you find the will to do those things. It all goes together. Yes?
Someone's earlier question was about OB identifying them, and for a lot of the moms that I see who don't have a doctor after 6 weeks for themselves,
Yep.
They continue to see the pediatrician.
Yeah.
Or the pediatrician sees the baby and the mom's also there.
Yes.
So I'm thinking maybe the peds ought to be on the lookout for this.
Oh, yeah.
Sometimes they can treat. I know when I say sometimes they can treat, obviously the mom's not their patient, but if baby has thrush, then they're going to do the logical thing often.
Well, that's a great point. And in fact, we've reached out to the pediatricians in our community. They have, our information in our 2 counties, Manatee and Sarasota. That would be amazing to get this information to more pediatricians. Here are usually the stumbling blocks, and we'll get to this toward the end of the presentation. Some folks are totally on board. They see it. They realize we'll say, you are not there to treat the mother. They'll say, we're not mental health professionals. Of course not, but you're a point of contact. That's all it is. She won't go to a doctor for herself, but she will bring the baby to you. So you're a point of contact. And you might want to, here's the tricky part. Every time you see her, give her our information again. Every time. Every time. Or draw to her attention. Even if you just keep them on the exam room walls. Just want to make sure you know about these new mom services in town. And they're really nice folks. And we want the pediatricians to say us by name. I know Sarah and Rebecca, they're great, they're moms too, and give them a call. Make it really personal. Because if it feels like an 800 number, why do it? They're moms in the community too. I know their kids. They go to my kids' school. Build a family around her. Pediatricians are a wonderful resource. Some of them catch the vision, some of them don't. Everybody's got their focus. For some of them, they're really focused on behavioral issues and autism, and they're like, I can't deal with one more thing. Okay. But if you find a pediatrician that, picks up on it, that's awesome. Absolutely. This is near and dear to me because I know a couple people who have been misdiagnosed with bipolar 2 in the postpartum adjustment period. So this is just something to be aware of. Like I said before, second opinions. Second opinions before we start antipsychotics that then leave us flat. That's the biggest problem, is if there's a misdiagnosis and then she starts medication and it's a cocktail of medication and now she's not really, it's the wrong combination. And now attachment with baby suffering, but she's too afraid to stop because what if all the symptoms come back? It's a mess. So before we jump to, oh my gosh, I think you're bipolar, we might want to actually look at things like, how much caffeine are you consuming? When is the last time you slept? When's the last time you slept for more than 2 hours at a time, or 3? I know some moms that drink coffee and eat Fiber One bars all day. I mean, what's that going to do to your health? So we need to start with the basics first. And moms that are so freaked out that they check themselves into, they go to the ER and describe these symptoms and then get diagnosed with bipolar 2. I mean, like I said, definitely it can awaken a mental illness, but it's certainly worth a second opinion. So what's our overview? It's measured by, how do we know the difference between baby blues and PPD? Timing, duration, severity. It is the top complication of childbirth. Many expressions, we know the 6 now: depression, anxiety, OCD, PTSD, panic. I didn't talk about panic. It folds into anxiety a lot. Definitely it can be a real surprise for a mom, especially if she's in the car. So we want to encourage her to talk about those things. And postpartum psychosis. So bipolar disorder and schizophrenia presents an elevated risk of postpartum psychosis. And we want to build trust, engage, and fight stigma. Fight stigma. I mean, that's what so much of it is about. Whether it's the stigma of having a so-called mental illness or just the myths of motherhood. Just being real. Being real and being present. And bringing your own amount of emotional vulnerability. And frequently, this is a stumbling block for a lot of us. I know it is for me. If you have a lot of experience with new mothers, and as a mother yourself, you bring all of that to the interaction you have. And so you might be able to intuit what you think she's going through, and you start filling in the blanks for her without really asking all the questions, because you don't want to put her on the spot, you don't want to make her upset, we don't want to bring up a bad topic. But frequently it's right behind, it's what we call the doorknob confession. Like, we'll close group, and then we'll say, is there anything else? Is there anything else? One last thing that you're going to get in the car and say, shoot, I wish I'd said that. One last thing. Or just linger at the door a little bit. kind of let silence lay there for count to 20 or 30, because sometimes they need that silence to just say, you know, I don't really feel that good. And then tell me more about that. Lots of open-ended questions. I'm really glad you're talking to me about it. You know, I think you're really brave and strong to tell me the truth. That's hard. We talk a lot about being strong. It is strong to reach out for help. So the rest of the presentation is about what we're doing prevention and treatment-wise. It's not all hormones, because as someone asked me about earlier, with placental encapsulation, that can really help a lot for moms, but it doesn't change the other what we call situational factors. If baby is colicky, if dad is not supportive, if she had a traumatic birth, history of fertility problems or pregnancy loss, not having any peers, or just feeling like she doesn't fit in, wanted to breastfeed, breastfeeding fell apart, wanted to have a natural birth, had a cesarean section. Certainly, one of the first places we can look is thyroid. If a woman is experiencing symptoms of postpartum depression, that's a great place to start, is get her thyroid checked. And if the OB has already kind of set her out to pasture, please network in your communities to find PCPs, primary care providers, as well as internists. You know, see who takes Stay Well, see who takes Medicaid. We are working with some of the folks in the health department as well as coastal behavioral health to cultivate those relationships. You know, any physicians that you know, it's all about networking. Like, who do you know over in that, you know, medical practice that I could talk to about bumping a new mom to the head of the line? People want to help. But when she calls and says, I need an appointment, and they say, well, we can get you one in 4 weeks, she goes, oh, okay, thank you. Because she didn't know. She doesn't want to be a pain, and she thinks, well, then that's it. So that's where you get to be the advocate. Why don't I make the call? I know the folks over there, and then you say, you just squeeze her in maybe next Tuesday, or I could bring her. I mean, you know how it is. You want to do a favor for someone in need, but you don't know unless they tell you. Diabetes, certainly any sort of endocrine imbalance. Stress and exacerbating factors, the high-need baby, for sure, breastfeeding issues, marital stress, a history of pregnancy loss, termination, abortion, certainly a history of sexual abuse, fertility problems, that sometimes surprises people. You know, I waited so long for a baby, and the baby was going to solve everything, and then, oh my gosh, this baby's staying. They're not going home, shoot. It can be a real shock, and that's why adoptive parents can have PPD as well. Motherhood myths and expectations, identity, perfectionism, all the things that we thought we were going to do for our babies that aren't working. We talk about that in group a lot too, that it's hard when our personal values don't line up with what our baby needs. You know, cloth diapering was really important to you, but actually you're spending so much time doing X because baby is colicky that you can't do it. Again, it comes down to giving her the chance to tell the truth. Give her the chance to have that dip. Go down with her in the dip and say, yeah, that stinks. You really wanted to do that. That's hard when you want something so much and it just doesn't work. She just needs to be heard. Because if you're like, it's fine, I use disposable diapers, they'll be fine. She's like, You know, once again, I'm misunderstood. Just give the chance to just kind of sit with her in the low for a minute. Prevention. Prevention is the great challenge of postnatal illness, because this is one of the few areas of psychiatry in which primary prevention is feasible. Is it okay? Okay. Yes, it's an amazing thing. So we know who gets PPD, we know how to get in touch with them, we know when it happens, and we're connected. So let's prevent it. However, it's a little bit more complicated than that, right? Because we can't tell by looking. And we know that we don't want to burst that pregnancy bubble. But why should we attempt to prevent? Because it is the top complication of childbirth. And when we work and reach out to prevent PPD, we can create bonds. And we also know that the risks of unaddressed PPD are well documented. long-term mental health difficulties, child's behavior, learning, attachment, abandonment, abuse, substance abuse, disintegration of the family. That's just the truth, really. And that's actually why I stepped into this role and began working with new families that are experiencing PPD, because as a family lawyer, I would see, I see folks and think, maybe it didn't need to be that way. Maybe if someone had been there, the mother is the foundation of the family, to support her better at the beginning, then this family could have had a better chance. And I really do believe in that right from the start. So what are we trying to do? We want to prevent or really reduce isolation and escalation of crisis. Certainly we've got Healthy Start and a lot of other great organizations that are addressing basic resource and psychosocial risk factors. We can go a long way just by being a model of wellness, and as I mentioned earlier, allowing some emotional vulnerability. Let them know that you're real too, because when you're at a low and someone comes in, like the lactation consultant's like your angel, you're like, oh, she's here, oh my God, she'll know it. Oh yes, and whereas before you might have been modest, you're like, yes, here, right here, just put your hand right here, and then it's so amazing to have that connection. But then mom starts kind of idealizing her lactation consultant a bit, I can't tell her what's really going on, she won't like me anymore. Putting y'all up on a pedestal. So it's great to keep that kind of realism. Barriers do exist, and prevention can feel threatening. But there are some great things we can do. I know that there's some group programs. I love this called Centering Pregnancy in California hospitals, where women actually have prenatal appointments together in a group. Isn't that beautiful? I love that. I'm yeah, kind of fizzled back down. It's an amazing thing, because once again we're building those bonds. They're able to connect with each other before the rubber meets the road. And so what a terrific thing. And even if only to get everybody together on a Facebook page. I mean, just some names, just something so they don't feel so alone. One group appointment, two, anything is a great way to get connected. I also created a motherhood preparation course in Sarasota and Bradenton based on using personality type, Myers-Briggs personality type, to adjust to motherhood. And we've done that as a webinar, and then I recently did it the last 2 weekends as well. And I really like to bring the dads in and do it as a pair, because, again, it's about communication. And when they're both under stress, everyone becomes exaggerated versions of themselves. So if mom used to be talkative and dad was kind of quiet, now she's alone all day and she's super talkative and lonely, and he's totally shutting down. Just like, he won't even talk to me. It's like, I don't know what's with her. So it's really helpful, to put that in a different framework where no one's right and no one's wrong. We just have different needs. Because really what baby needs is two parents, and really what mom's needs is the partner support. If there's a partner in the picture, it's his support. So we have the opportunity in childbirth education classes, for sure. I love when childbirth educators are okay with me popping in and just saying, I don't even say anything about PPD. I really don't. I'm just like, my name's Sarah, and I run a group on Thursdays, and there are a lot of moms there, and we, whatever's going on, it's really a group for moms to talk about what's going on with them as women, not really talking about babies. We more talk about, like, what you're going through with your motherhood adjustment. So I didn't say anything about postpartum depression or anxiety. They just know that I'm there, and I'm not there to church them up, I'm just someone that they can get in touch with. And, that face-to-face contact goes a long way. Couples classes that engage partners are great, but, usually the moms that are at the highest risk for a lack of support, they're not going to those classes. So we need to find other avenues. If there are any local baby stores, or if, Target lets you put something up on the bulletin board, anywhere like that. I wish Target would let me put things in their bathrooms, but they won't. But that'd be super helpful. I'm going to skip through these. This has to do with our preparation for parenthood by Myers-Briggs personality type. So Myers-Briggs is usually used for the workplace, but we say when you have a baby, the home becomes the workplace because now you're running a laboratory, a hospital, a daycare, all of the above, a restaurant on your chest. So these are some of the stress triggers by type, and if anyone knows their Myers-Briggs letters, yeah, you might recognize some of these. Yeah. Yes. Can I see a show of hands? Does anyone know their letters? Okay, just a few. So this is about whether you prefer extroversion or introversion is E or I, and whether you prefer, whether you tend to make your decisions based on feeling is the F there in the center. Okay, or thinking, objective, logic. So it's tangential, but the point is this is really validating a lot of times for moms to be like, oh, I see, I'm not supposed to just be a good mother and have nothing ever bother me again because, that's what I saw on Donna Reed, and we said recently, we're like, Donna had a script, and I think she was smoking between takes, so she had a trailer, and that's not, there's more to that story. But it's really helpful to see that especially for the E's there, isolation is so stressful. For the feeling types, conflict. For the E's also, a lack of feedback. For the folks that prefer a certain type of interacting with the world, repetitive or boring work or constant decision making. Yeah. Yes. Yes. Oh, yeah. Of this. Yeah, this is the other hat I wear is I'm a Myers-Briggs type instructor, so this is very dear to my heart. I work with adults and children as well as schools and so on, because I am an ENFP and my husband is an introvert somewhere over here, an introverted thinking type, and boy, we adjusted to parenthood so differently. And just now, he's like, remember 6 years ago? That was really hard on me. I'm like, oh, I had no idea, because you never said anything. So, who knew? Just defragging the computer. I didn't know. So, yeah. So it can be really validating to have them see, like, oh, these issues are difficult for me, and that might be okay. That some things are hard, and that I could just leave the house. Instead of do the laundry, like maybe you just need to go. Or for someone who prefers introversion, everyone says, get out of the house, get out of the house. She's like, I don't want to go. I want someone to take the baby away so that I can think. Yes, right. Yeah, so that might be an issue too, is everyone else is, people tend to recommend what works for them. So this puts it in the framework of figuring out better what works for you. Oh, yeah, absolutely. Absolutely. I'm so glad. It has been really helpful to our moms, too, especially to some of them, for some of the dads, that it's stressful to be on another's agenda. Sometimes that's really hard for people, moms and dads, to adjust to, is that resentment you feel of like, oh, it's nap time again? I was just about to do something, and then you're like, well, it's not the baby's fault. And then, like, the motherhood guilt sets in. Oh, I'm so mad mother because I'm so upset. Forget it. Some things are stressful to people. You are working. As a parent, you're working. This is your workplace.
On a personal level, my daughter is now 14 months old. And when she was first born, I'm an ENFJ.
Okay.
My husband's an ISTP.
Oh, my.
Yes.
Oh, my gosh.
So, just based on the chart, I'm like, that makes sense. Because we're very, very, very different in a lot of different ways. Obviously, we have a lot of commonalities too, but
Sure. Well, you balance each other well.
Yes, very much so. Based on, now he's home today with her, so I'm phone close. He's never done that ever.
Yeah.
So
Yes. I feel your pain.
It's
I know.
very, now that I'm looking at this, I'm just like, so when can I have this chart
Absolutely. Yes. Well, up here in the front, everybody's going to get a book and CD in my card. So please email me. Yes. Oh, yes. I love making friends because I am an ENFP. So I really like, yes, new experiences and coming together with people. So that's lovely. Oh, you're welcome. What's that? Oh, absolutely. All are welcome. We're very inclusive. Very inclusive. Yes, it is. It's really helpful. And who was it the other day? Oh, I remember. Yes, we have another mom in our group where her husband is an ISTJ, which is an introverted, sensing, thinking, judging type, if you're unfamiliar with this. Introverted gets the energy from inside themselves, sensing, takes in information in the present, facts and details. Facts and details. Especially a judging type. Thinking type makes decisions based on detached logic. They tend to point out what's wrong rather than what's right. Because if it was right, why should we talk about it? I mean, leave it alone. Let's fix what's wrong. Like, after 11 years of marriage, I really get it now. And my son's a thinking type too, so that's my 9-year-old, so that's been an education. And the judging is preferring to order our world rather than the perceiving. The P stands for perceiving, exploring our world. So the judging type, the J, tends to control their world by sort of organizing it. I don't mean perceiving types aren't neat, but like there are file folders sort of in their minds. And perceiving types sort of swim in the bucket. They're like, ooh, what's it like in here? And they like to order their world by being, they control their world by being spontaneous and flexible. So if the J is under stress, whenever we're under stress, like at normal healthy functioning, that's all great. And then we're exhausted and we haven't eaten and we're starting to go batshit crazy. I'm sorry, that's how we say it at group. That then we're sort of hyper versions of ourselves. We're super selves. And so if before you were structured, now you're really structured. And if before you were detached and logical, now you're like cold. And if before you were a feeling type and tended to, need appreciation, now you really, really, really need reassurance. And if you were a perceiving type that liked to be flexible, now it's like mashed potatoes up here. Like you can't, it's hard to organize anything. Some of the perceiving type, I do this every quarter with the moms in our group. Whoever's around, they get to take the Myers-Briggs test, and then we do a month-long. We have a 2-hour group, and the first hour and a half is chatting, and venting and sharing. And then the last half hour we do discussion focus. And so we just did this in October, and I'm going to do it again. And they're so funny when they're like, that explains everything. Like they'll just look at the sheet and they'll be like, now it explains everything. Because one of the moms he's an ISTJ and she's an ENFP. And they're really good balanced. But when they're under stress, now it's like this. Okay? And so what's really helpful is when we can see the good that the other person is bringing, then we're twice as strong. But if we just stay entrenched in our position, we have to see it my way, then we lose that double strength. And sometimes people see this and they're like, oh my gosh, we're so different. It's like, no, but that can be a good thing. It's a good thing. Something brought you together. Yeah. Frequently, it depends on what opposite it is. Sometimes extroverts are frequently drawn to introverts because the extrovert brings a certain energy to the introvert's life, which they like, and yes, that's what it is. That's what it is. Yes, because the extrovert doesn't have to compete with the introvert. So they're just happy, but then it's a real surprise when the introvert's like, oh, good, I've got you. Now we're going home. And the extrovert's like, wait, no, I want to stay out in the world. And especially if the extrovert ends up being home with baby. And then the introvert gets all of their socializing at work. And they come home and they're done. They're just spent. There's nothing else to give. And that's when a lot of arguments can start. I mean, I remember standing there on the step, on the front porch waiting with our oldest, waiting for him to come home so I'd have somebody to talk to. And then I realized I could talk to like the lawn guys and the mailman, and everything's fine. I know, a friend was like, I invited the plumber to stay for a sandwich. I was like, that's a step too far. Like, we're going to get you to some good counseling. But yeah, I'll definitely get you this chart and more. And if you'd be interested, the next time I do a webinar, it can be very helpful. Yeah, for sure. So prevention in the prenatal period, what can we prevent now is a lack of information, certainly, and we want to prevent the perpetuation of motherhood myths. We got to be really careful about this. I do it too. You see a little baby, because they're so cute. And so like, and then you say I remember those days. Oh, enjoy every moment. Enjoy every moment. And she's like, it's like, I enjoyed the moment all through the night, and the night before that, and the night before that. I mean, I don't know what you say. I was really thinking about it on the way here. What do you say? I don't know. There's no pat expression. Mm-hmm.
I tell mommies that the 24-hour period in the day seems like an eternity, but the weeks kind of fly by.
The weeks, it does.
You gotta stay in the moment. Don't think about the next feeding and the next feeding or that night.
You'll go crazy.
Don't sleep.
Yeah.
They got the opportunity, but they stay awake because they're anticipating the baby's going to wake up.
Absolutely. They're living in the future.
Stay in the moment. Just be right here. And I know it's an eternity each day, but it does get better.
It does get better. And that happens more actually, if I can go back to this slide for a second. The N in there stands for intuition, and those are the folks that tend to live in the future, always looking ahead to the next possibility, the next horizon. And the sensing types tend to live in the present. And I do see that more with moms that have that intuitive preference. They're thinking ahead to the next thing, to the next thing. You get a lot of worry that way. And you can have the sensing types worry too, but it's a little bit different. So it's a nice way to exact on that. So we want to be careful about how we idealize motherhood and babyhood, even in those momentary reactions. Or, something as simple as like, she's beautiful. Or like, I don't know, what did someone say the other day? Oh, when people say, oh, you've got your hands full, it's the worst thing anybody can say. And I know, isn't that the pits? Why do people say that? You're like, yes, thank you. Thank you for bringing that to my attention.
I hated my first were twins, and I hated when people would say, oh, double trouble.
Oh, I know. I know. Somebody said to me not long ago, I was out with all 4 kids at Target, and they love it because we get the cart with like the thing in the back, and it's like the fire engine, they're so funny. And someone's like, have you figured out what's causing it yet? And I'm like, no. I was out working in the yard, and the next thing I knew, I was like, oh my gosh. I have a lot of baskets, and a lot of storks come by, and I don't know. It's snowbird season too. People are weird. So, but anything that's just, anything at all that doesn't make her feel as if, yet again, she's missed the boat. Like, oh, embrace every moment, Who knows? But then you say that one time you're like, it can be tough at the beginning. That's when she's like, I'm fine. You're like, okay, I just won't say anything. It's, emotions run high, so we want to be careful. This is more about the studies. This is basically just illustrating the fact that we know that if we rely on self-reporting alone, that we're missing at least half of the moms that are suffering. So that's just the reality of that. So we can turn to screening. Okay, I'm all for screening. It is not a cure, and it is not a treatment. It is a tool, and it can be a very useful tool. We use the Edinburgh scale. Some people call it the Edinburgh scale. In Scotland, they call it the Edinburgh scale. Whatever. The EPDS, it's the most thoroughly validated, and it's free. However, it is not linked to the DSM, so the score does not reflect the severity of the symptoms. There's the Postpartum Depression Screening Scale, which was developed specifically for PPD, which is great, but it must be purchased. So if you have funds, super duper. Patient Health Questionnaire, the PHQ-9, 9-item. It is, self-report, linked to the DSM, no cost, but it's not well validated for for perinatal use. It's generalized depression. We had a pediatrician in Manatee County that was using the PHQ-2, just 2 questions. And that's good. I mean, listen, anything that'll help. If you find it's helping, do it. However, I mean, this sort of national mandate of throwing another piece of paper at somebody is just not going to get it done. Okay? It happens one at a time, person to person. It happens with us being ambassadors and forming relationships. It does not get solved with a piece of paper. Because what we say is, mom passes the screening because she doesn't understand it, or she passes the screening because she does understand it. Because either way, she'll score 0. Either she's like, I don't know, 0, and you're like, 0? Really, 0? 0? Okay, well. And then you see someone else who's like poring over it, and then she comes out at a 0. You're like, it could not have taken that much thought to get to 0. Because she knows what it is, and she doesn't want to get dinged. Screening for PPD. All providers who have contact with postpartum women should screen. That means pediatricians, as you mentioned, it really does. Pediatricians. So it can really start with our own children's pediatricians talking to their practices. It's personal pleas. Screening tools are not diagnostic. And what do you do with it? Everyone says, I don't want to screen because then what do I do? Then I've got a problem. You refer them to a mental health professional. I often say, like, you know, Walgreens, you can get your blood pressure screened, but then they're not on the hook if you have a heart attack. It's just a screening. It's just a screening. So if you happen to, you know, she scores positive on this, then you say, you know, here are some resources. The one exception is one of the questions on the Edinburgh scale is about self-harm. And if she says that she's thinking about harming herself or others, then that becomes a really tricky spot. Then that's a professional judgment call. Mm-hmm. Yes.
But in my world, I've seen mothers who want to breastfeed or are breastfeeding. What their concern is that they admit they're not feeling well, that they can't breastfeed.
Mm-hmm.
And I mean, my own personal
Yeah.
position, I remember she called me and said, well, this woman came in and she's depressed, so I told her she shouldn't nurse anymore.
Oh my gosh.
Oh yeah, and put her on this medication. People think that taking the baby, responsibility of the baby away from the mother, putting them on medication is what's going to help them. That's what I see in my community.
Now tell me, so you're here in Orlando.
No,
No. You're in Tampa.
you know, my concern is that when I do a consult with a mother and I
Yeah.
ask these questions,
Yeah.
I'll look right at her and say, you know, you can take medications while you're breastfeeding.
Yeah.
And many mothers will say, oh, really? And they are led to believe that they admit this, that they can't breastfeed, and that's one of their dreams to do that.
Is that right?
So
Okay.
that's where I see the problem.
Yes.
The pharmacist says that they can't breastfeed while on this medication. And so they're left with deciding, do I feel better or do I fulfill my
They're going to try to go without the medication so that they can attempt to
Oh my gosh.
get the breast milk to the baby.
Whoa. Are you, okay. See, because this is really interesting because I give this presentation to social workers, counselors, lactation consultants, childbirth educators, and so everybody has their own, you know, population that they serve, what they're seeing. I'm so glad that we're having this conversation because in my neck of the woods, that is, I don't know if it's just because Sarasota is a little crunchy. I mean, I don't, you know, it is. I love the crunchiness. I love it. But it's very, you know, I mean, breasts flying and walking on the beach with the ring sling, with the whole 9 yards. So it's very breastfeeding friendly. And I'm so glad to know that that's a concern because I thought, foolishly, in my corner of the world, that was a settled issue. Absolutely, you can breastfeed and take medication. That's what they told me in 2005 was I had to choose. That was almost 10 years ago. It was 10 years ago. Oh my gosh, in Miami, that's what was said to me was, well, I can write you a prescription, but you can't breastfeed. And I chose to continue breastfeeding because I felt it was the one thing I was doing well, and I didn't want to lose that. So I understand exactly what you're saying, but there's a wonderful book by Dr. Thomas Hale called Medication and Mother's Milk. Everybody knows.
But that doesn't mean the doctors are the initial person they talk to, and a lot of times once a doctor has
Once a doctor says it, then that's it. Right.
I can tell them it's okay.
Yeah.
The rheumatologist can tell them it's okay, but there are still some moms that are going to say, no, this other person said no.
Because if one says it, then it opens the door. Then it could go either way, and then now I'm too scared. Of course not. No, of course not.
Pharmacist will say, the pharmacist with that sticker on the bottle that says, you know,
And I explain that pharmacist thing by, we don't test drugs on women, we only test drugs on men. So everything is labeled not for nursing.
Right, not for pregnant women.
Because we cannot legally throw our butts out in the FDA with that.
No, that's right.
It's all about testing of the drug, it's not about the drug.
You know what I would love is to see, and this is just off the top of my head, I'm going to have to take this back to the think tank, is to give, you know how there are the cards that Healthy Start gives out and other folks that say if someone tells you that you can't breastfeed there, that you give the thing, right? I would love to have a card that says when you go to the pharmacist's office or you go to the doctor's office that has a little blurb that shows like, actually the medical research says, and here you can look this up if you want to, I can take medication and breastfeed. So she has it on a card, and then it deflects that one-on-one thing, because sometimes it's like a doula in the delivery room. You need that other point of proof or advocacy. I mean, I think that could be useful. It's just a little token, but it's something so that she doesn't feel like she's always, you know, back and forth. Because no, absolutely, I mean, for Pete's sake, yeah, exactly. Yeah. Yeah. I mean, but you're happy that they're doing what they need for their wellness. Well, thank you for. No, I mean, in my neck of the woods, it's like. Yeah, come on down. It's a great. We're up and coming. Yeah. Yes. Yes. Wonderful. But here's the thing. They won't read it, but what you can do is 1 page, 3 points. 1 page, you give them the book with 1 piece of paper clipped to it that has your 3 favorite quotes from in there. It can be something as simple as, you know, research shows from such and such that, you know, this class of drugs does not affect the quality of the milk. This is it, you know, page whatever, footnoted. They don't have to read the whole thing, but that's it.
Their lack of logic, because I've even had it for things that you have to inject it because you can't take it orally. Something like heparin.
Yeah.
You know,
Yeah.
Rosepen.
and you know,
Yeah.
and you think that the baby's gonna get it. If you can't take it orally, you have to inject it.
Yeah.
It's such a large molecule.
Right. It doesn't make any sense.
You know that?
There's more mag sulfate in formula than there is in the mag sulfate bottle.
Is that right?
But their logic is liability.
Well, yes, their logic is liability, and it's also, I mean, let's face it, it depends on the focus of their interest. What was their interest? What were they paying attention to when they were going through their residency? Because they're not superheroes. They're just people, and so they were paying special attention to cystic fibrosis or ADHD or whatever it was. And then they had like that footnoted section about lactation, and they just remembered, oh no, you can't take drugs when you're breastfeeding, because that was the pearl they learned to pass their board exam. I mean, it's so limited. It's like I said at La Leche League, it's a drive-through knowledge of lactation. And so I think giving books is a fantastic idea. And finding a way to put right on the cover, so even if they don't read it but just their practice manager reads it. Also, it can be helpful to take one page and fax it to the office because they really tend to get their information through fax. One page that just says, like, those quotes, and then it has to be footnoted with the journal article and the pages, because all they really want is literature-specific information, something where they can look at it and be like, oh, and you can even say, there's been, recent research shows, so it's not like, you idiot. It's like, there's been a change, exactly. So it doesn't like, just, heads up. Yes, go ahead.
I took my copy of Hale to my pharmacist, and I said, when one of my moms comes in, what do you use? Oh, he said, I have that online. So I think our moms have to dialogue and advocate for themselves.
Yep.
At the doc's office and then at the pharmacy, because they do have these resources available.
And that comes down to what we said before, which is that communication is everything. Communication is everything throughout this process because she's dealing with so much. In the delivery room, afterwards, with her physician, with her counselor, even now we're finding out with the pharmacist. And how can we help her with communication? It's about preparing her, and that's the reason why I wrote the book, is if we just give someone a heads up ahead of time, like, this might happen to you. And if it does, this is what you do. Then they're armed, they're empowered, they're ready. But it's just like, go and get some medicine. Okay. And the next thing you know, they're getting pushback. If we arm them with knowledge, that is so powerful, and then they feel ready to meet that challenge. So the outcomes of untreated postpartum distress, I know I need to wind down. This has been so delightful. Of course, is impaired bonding, failure to thrive, unable to self-soothe. One thing we talk about in group when I have a discussion focus, we just taught, this last week was about to beat boredom at home using interesting words. It's boring to be at home sometimes. And instead of just saying, like, is it time to eat? But, like, how else could you say that? Like, is it time to dine? Are you feeling ravenous? Are you, do you have an appetite for, anything to kind of keep their minds active and get us out of that grind. Yeah. Because it builds that rich vocabulary, which is only good for early literacy. The more words they're exposed to, right, it will help them not only learn to read, but become proficient readers. My background is music, so I taught family music, and the more, like, songs and words, different words we expose babies to, the better they'll do. Yeah, talk like that to your babies, and then moms are like, really? Like, yeah, use words that are interesting to you. Like, oh, and so then it's like doing a crossword puzzle in your head, and it kind of keeps us sharp. So we do a lot of different discussion focuses. That was one, and another one is practice your smiling exercises. Because sometimes we'll go through the whole day like this. And especially when the baby cries, we go, oh. Because we're mirroring the baby. When what we want to do is come to the baby, it's all right, because they'll mirror us. And so also smiling releases good chemicals, right? Makes you feel better. And so we're like, practice smiling 5 times a day. It was so funny when we did it one time. Someone was like, ow. She's like, I haven't done that in so long. I'm like, I know. We need to practice. But that's one of the things, too, is if this is left untreated, baby isn't exposed to much smiling, it really has that debilitating effect. Lower cognitive abilities in the child, language and problem solving. And of course also general chronic health concerns. So where to get the screening tools? You can find anything online. You know that. Barriers to screening, diagnosis, and treatment. We have 2 sets of concerns. Provider concerns. Time and expense are always an issue. Of course, it's liability and protocol. Patient concerns, stigma, fear of repercussions. And I guess folded into that would be fear of losing the opportunity to breastfeed. Yes, that someone's going to say, well then, this isn't compatible. The value system or being a good mother. The fear of the support system response is really too bad, but for sure there's like, well, my mother didn't have this problem, or feeling like she needs to do things in secret. And that's another reason why that stress triggers by type chart can be so helpful, is to say, but you're not your mother. Maybe Maybe everything was all stacked up so it was really simple for her because she thrived on all of these things. You have a different life and different needs, and you're a different you. And so to break that out, be like, oh, yes, I do, you know. Sometimes we say, like, maybe she likes mustard and you like ketchup. You know, you guys are different people, and it's okay to approach yourselves in different ways. The only thing with screening is the accidental chilling effect. Because if someone screens and then they get an answer to the self-harm question, then what do? And it's really, really difficult. I don't have an answer. I really wish I did. I don't. It's awful. I mean, I know some practice where they insist on calling the sheriff and having him escort her to the hospital for an evaluation. That's great. That's great, right? Then all the patients see that that's what happens with moms that are feeling bad as they get taken away by the police. Yeah. So that certainly encourages self-reporting. What I would love to see is every OB office be able to consolidate their postpartum appointments so that a care coordinator from Healthy Start or other counselor is there. Wouldn't that be beautiful? Yeah. So that she's there to give them an evaluation on the spot. That's really what should happen, because there's a gap in maternal wellness. There's a gap in health care because we're treating the body waist down and we're not treating the whole person. I beseech all of us to work on that in our communities. We do have right up here, one of our tools is a CD that I created. It's called My Tunes, and every mom that delivers in our 2-county area, 3 hospitals and 2 birthing homes, gets a CD. And we created it to improve bonding, support, and self-reporting. So you'll hear it, and you'll get to see what you think. It's 14 children's melodies with some new mom messages, and then 2 original songs to encourage self-reporting. We wanted something that would be useful to all moms that wasn't a flyer. So if you find that you like it, it's useful, you'd like to have it for the folks that you see, let me know, because when I buy them in bulk, I can get them for as low as 50 cents per CD. And that's why we fundraise, is if you find it useful, I'd like to supply it to you at no cost, if that's at all possible. Because we're all from Florida, what we're aiming for is to improve our perinatal network and response throughout the state. That's our goal, is to blanket Florida with perinatal support. We are blessed to have a lot of room for improvement, and we're blessed to have a lot of great energy and know-how going toward this. So how do we feel better? The treatment plan is extremely individual. There's no silver bullet, and that can be really hard for moms to accept. Once they realize they have a problem, they're like, I want it fixed now. What do I do now? No, I want to feel better now. And some of it is just like the broken bone analogy. This is going to take some time, and it's hard to be patient. You will walk again on that leg. You will feel better again, but you need to go through the hard work right now, and we're going to be with you every step of the way. Part of it is patience and not arguing with her that she wants it now. Of course you want it now. You want to feel better for your family right now. Who wouldn't? You have every right to want to feel better right now. And it sucks that you can't, that you don't, and that it's going to take time, and we're going to stick with you, and you can fight this. And finding a way to let her have her feelings and not argue with her about them. What we usually say is, for treatment options, 9 times out of 10, 99 out of 100, start with a mental health professional. It's really the best way to go, because I'm not a mental health professional. I certainly don't want to miss anything. So we encourage that. There are some support groups that kind of require their moms to also have counseling. We do not require that. One of the biggest challenges is getting a mom to see a prescribing provider, because OBs really don't want to prescribe anything beyond Zoloft or sort of a low-level antidepressant. And if she does need anti-anxiety or mood stabilizers, then she needs to see a psychiatrist. Another great resource, though, is psychiatric nurse practitioners. So we've been really happy to cultivate some relationships there. We certainly encourage utilizing perinatal professionals and doulas. Some moms prefer a natural sort of holistic route. Frequently, it is breaking through the barrier about the stigma of medication. And if there are other moms that you know that are taking medication that are willing to talk to someone who's on the fence, that can be helpful too, because sometimes they just need that validation. And the basics, a sleep plan, especially for a breastfeeding mom. How are we going to enable you to get a little bit more sleep? Can you pump one of the feedings in the night so that dad can give it or someone else can give it, even if it's once a week? The power of peer support. Peer support is not a cure, but it is frequently the most powerful tool that a mom can have in her recovery. These are from our moms. Saved my life and my son's life, life-changing, the best thing I've ever done for myself. We use a lot of cognitive behavioral therapy approaches, positive self-talk, communication. We do once a month what we call chain of kindness, where the ladies all compliment each other, which is really lovely. You have to be careful that it's not a lot of you seem like, because then it's like, oh great, I seem like this. But actually we want to compliment what they're really doing. I love how you respond to her cry. You know, I notice you picking her up and talking to her softly, and that's really lovely. We want to compliment what's actually happening. And emphasize that there's safety in numbers. We were not meant to do this alone. We also have a secret Facebook group. It's not a closed group. It's not an open group. It's a secret group. And no one can see it unless they're part of it. It doesn't show up on anyone's profile. The ladies have loved it. It's been what really allowed us to gel as a support network. We want to be sure that the folks that are in the medical community have a mental health referral network. And, you know, ideally we'd have mother-baby beds in hospitals, but one thing at a time. We are offering, I'll say this, it's pretty much already begun, but if anyone is interested in the social support aspect, there are 2 webinars going on presented by PSI, Postpartum Support International, and the 2020 Mom Project. One of them is for maternal mental health training for mental health professionals. That's closed. But we were able to cultivate 15 folks from across the state of Florida in 6 different counties to take this webinar, and we are paying for it. So that our goal is to have at least one mental health professional in every county in Florida by 2020 who is trained in PPD. Because time and time again people say, but who specializes in this? And then you call somebody and you say, do you specialize in PPD? Oh yeah, I treat people with depression. Different animal. Oh, you bet. So that you know. Absolutely, absolutely. I will pass that along to whether it's Ellen or Diane. Yes, yes. There's also a webinar going on called the Social Support Network, again, by PSI and 2020 Mom. And we have, I think, 16 doulas taking it from like 12 different counties around the state, and the purpose of that is to familiarize lay perinatal professionals with postpartum distress, perinatal distress, and encourage them to know how to create social support networks in their area. And I still have money for that. So if you are interested, we called it the Help Scholarship Program. If anyone is interested in applying for that, which is really answering 4 questions about what are you doing now, what are you seeing, and what would you do with this training, I would love to offer that opportunity to you or anyone you know. Clarifying roles and resources. Of course, we need to be clear about our availability and ability to help. A great question is, what would make you feel safe right now? Referral and treatment process. As I said before, we can call for or help the mom call for and let her know when we give multiple referrals. It's best if we have more than one name for mental health professionals, but that if that first person isn't a good fit, it's like trying on shoes with mental health professionals. It's not always a good fit. Try something else. Try another person. Let me know. We just want you to have what you need. So this is sort of the overview at a glance. 1 in 3 new mothers experiences PPD for a variety of reasons, and prevention and education really can help. We want to encourage screening with non-traumatic protocol, and certainly use other means to screen, like with the CD, sort of screen privately so that she can reach out when she's ready. We want to emphasize that this is highly treatable. PSI slogan is, "You're not alone, you're not to blame, and with help you will be well." This is highly treatable, and that is such an encouraging thing to hear. And sometimes we feel like we've implied it, but we haven't actually said it. You are not alone. You didn't do anything to deserve this. You deserve to feel well with your baby. You deserve that. And we're going to stick with you and find a way for you to feel better, because this is treatable. Moms can feel better. It happens all the time. You will feel better if you take these steps for yourself. You'll find your way. You want to be careful to not promise that if she calls this person, she'll feel better. But if you take the steps and do the work, you will feel well. And that can be really encouraging. So, of course, my card is in each one of the books. Contact me. I will say that my New Year's resolution was to spend less time on my laptop, because I do have 4 little children, and I used to work a lot when I nursed in the night. When she was, I'd have her on the boppy. But life has changed a bit, and now I have 2 toddlers, and so I might take a week to turn it around unless it's urgent. But no, I haven't forgotten about you. I just started to see the irony in me helping other mothers not feel stressed out, and I was in a dither. And I'm like, that doesn't work. So I've taken kind of a more toned-down pace talking with providers, but if a mom gets in touch with me, I will return her call within 24 hours. On the weekends, Fridays are returned on Mondays. So I just want to thank you so much. I'm sorry I'm a little bit over for having me here today. It's so helpful and meaningful to raise awareness and have the opportunity to collaborate with all of the good work that all of you are doing. I deeply appreciate it. And we know that no kind word is ever wasted. In working with the guardian ad litem, I learned very, very clearly that just one person is really enough to turn a whole life around. So thank you so much. I'll be up here for a minute if anyone has any questions. Thank you.
I'm going
Welcome to.
I'll post it on the